Assalamu alaikum, welcome everyone on board. So first question is about a 40-year-old male man with the brain tumor, GCS 15 by 15, minimum midline shift. Which volatile anesthetic based is least likely to detrimentally affect his intracranial pressure? Actually, before I think there will be a contrast in the ideas because before we used to think about isoflurane, but in the recent data, it's sevoflurane. So, uh, just few word about brain tumor. Whenever we are resecting any brain tumor, the things which you should be chalking down before is any baseline neurological injury. This thing should be like neurologically, if patient has any deficit, like they have mentioned here, 15 by 15 GCS, for example. So in this patient, as they have mentioned about minimal midline shift, so if there will be significant midline shift, there are some preoperatively raised sign of ICP, or patient has any neurological problem, sensory, motor, cranial nerves, so that should be documented. Then another thing is that sometimes these tumors are secreting tumors. Okay, so they have some like for example is pituitary tumors. So you should be knowing the effects of that secretions. So that thing should be in your mind. Then any specific area, especially for example if it is posterior fossa, you are expecting more of the postoperative neurological complication. Brainstem area is involved. They are doing it in prone position, they are doing it in sitting B chair position. So these things should be in your mind. Then in a number of neurosurgeries, they are doing neuro monitoring. Okay, so whatever anesthesia plan you do, you should be thinking about neuro monitoring, because these patient might need. Um, so in that patient, the patient in which they are doing neuro monitoring, you have to avoid anything which affects the sensory and motor evoked potentials, so you are mainly doing TIVA. And like these are the things you should be considering whenever we are anesthetizing a patient. Similarly, in this question, as they are asking about this, so this is one of the point, that which inhalational agent will be has the least effect. And this is then you should be knowing that this patient can bleed. So you always have a central line, arterial line, central line, not only for other reasons. Then here there are chances of venous air embolism. So we arrange one line for this thing. Then these patients, not only neurological problems, fits. If the patient has any chances of fits, also a number of time they load it with some anti-epileptic. So this is another thing which you should be knowing. Then, according to the length of the surgery, sometimes it's possible to extubate the patient, but a number of time, patient might need to be ventilated electively. So these are the things which should be just a quick revision of things related to craniotomy or brain tumor. So I just whatever I could like bleeding, neurological problems, air embolism, prolonged surgery, Cushing's reflex, neuromonitoring, navigation, then maintenance of cerebral perfusion pressure. Intraoperatively, number of times they use this mannitol to decrease the ICP. Okay, they can say tight brain. So what should you be doing for management of tight brain? You have to avoid hypoxia, hypercarbia, sympathetic stimulation. You have to maintain the viscosity, not to be too high viscosity. If you over transfuse, that will be a problem. And then, like these are the things which you should be doing. So I think I'm not sure whether it will be isoflurane or sevoflurane. So let's see what is the answer. Okay, so they have put it answer as sevoflurane. So all volatile have the potential to cause cerebral vasodilatation and affect cerebral blood flow. The resulting increase cerebral blood flow volume ultimately leads to an increased ICP, an effect more pronounced in cases where the ICP is already raised or there is evidence of midline shift. Cerebral blood flow is dependent on a number of mechanisms like autoregulation, cerebral metabolism coupling, biochemical reactivity, autonomic nervous system, and flow dynamics. So actually, these are the things which you should be knowing, that autoregulation is the limit in which the blood flow is maintained. Metabolism coupling means that how much is the metabolic rate and how much is the blood flow. So that's, I think, the cerebral metabolic coupling, biochemical reactivity, autonomic nervous system effect, and flow dynamics with reference to, I think, the volume or the blood flow through the vessels. So all volatile anesthetics inhibit the autoregulation, okay, which is normally maintained over the range of perfusion pressures. In this text, it is written 50 to 150, but actually, usually it's 60 to 160. I don't know why they have written like this. And the usual global perfusion is around 50 ml per 100 gram per minute, per 100 gram of brain. Okay, by causing vasodilatation, volatile agents outbound obtain the myogenic reaction of the arterial smooth vessel when exposed to increased pressure, thereby preventing the control of blood flow. This is range of effect across the different agents as listed below. Halothane, isoflurane, and desflurane, sevoflurane, minimal effect less than 1 MAC 1.5. Nitrous oxide disturbs the autoregulation in a similar fashion when used in isolation or with the other volatiles. Autoregulation remains intact, however, when it is used alongside propofol. But the increased risk of expansion of any air introduced into the cranium during surgery leads most anesthetists to avoid its use. All volatile reduces the cerebral metabolic rate as the cerebral activity decreases. Normally, this would be associated with a reduction in blood flow. But if the vasodilatory actions of volatiles are taken into account, the balance can be tipped towards increased flow. This is known as cerebral flow metabolism uncoupling. So actually, uncoupling means that there is more flow. Normally, this would associate with a reduction in blood flow. If the activity decrease, blood flow should decrease. But here, the vasodilatory actually blood is increased. It can be tipped towards increased flow. So this is cerebral flow metabolism uncoupling. So uncoupling is occurring at higher concentration of volatiles in order of potency as seen above. And biochemical reactivity of cerebral vasculature has been demonstrated with regards to CSF, pH, secondary to arterial concentration of CO2 and O2. Reactivity to CO2 is marginally affected by volatiles. Subsequently, vasodilatation seen in their presence can be opposed by hyperventilating the patient to hypocapnia. Clinically, the risk of induced cerebral ischemia with this practice is high enough to render it an emergency maneuver in the control of a raised ICP. Like they're saying that reactivity is not much affected. So we can have some cerebral vasoconstriction for a specific period of time, like if the surgeon is saying the tight brain. So immediately we can do it to achieve it, but not for persistent time because it will lead to cerebral vasoconstriction. Okay. Cerebral blood vessels are also responsive to the neurotransmitter release during signaling of autonomic nervous system. It is controversial as to how much this influences cerebral blood flow, thus theoretically reduce cardiac output. Secondary to presence of volatile anesthetics may play a part. So if the cardiac output is decreased, there is some effect in the signaling of autonomic nervous system. The flow dynamic may be altered by volatiles. Their incurred vasodilatation may prevent the ordinarily seen vasoconstriction of resistance arterioles. This would normally occur when they are exposed to shear stress of increased flow. I don't much have much because I did not read about this point before. No volatile agent is considered fully beneficial beneficial to the management of ICP, but sevoflurane is accepted as a gold standard in neuroanesthesia, as it is least likely to cause a detrimental effect if used appropriately. Actually, usually what we do is the number of time we are using, if we have remifentanil or fentanyl through TCI or propofol infusion. But of course, and when they are not doing neuromonitoring, they allow that we can use less than 1 mag. Here they have written 1.5 mag, but usual practice is that we try to do it less than 1 mag. So these are practical things. This point I have not read about it. The flow dynamics may be altered by the volatiles. So, anyways, this is just matter. A number of because there is a phenomena called Robin Hood phenomena, and so I think this is
Sir, about this flow dynamics,
yes.
sir. So about
Mm.
this flow dynamics, it means that at the level of arterioles, these volatiles they basically vasodilation causes vasodilation on those arterioles, and this will
Mhm.
increase the flow. Sir.
That actually I don't
Actually, this
understand.
point.
I don't understand. Their incurred vasodilatation may prevent the ordinarily seen vasoconstriction resistant arterioles. I think they are saying that the volatile they finish this flow dynamic um, uh, control through the vasoconstriction. This would normally occur when they are exposed to the sheer stress of increased flow. I don't understand. This is what's the clinical significance of it. Okay. So some of the points you can revise. Usually the use of steroids is there in brain tumors. So edema, cerebral edema, with reference to brain tumor, they use dexamethasone or hydrocortisone, but not for head injury. This is one point. Mannitol is being used 0.5 to 1.5 gram per kg. So you can say around 100 gram in adult, and you should be knowing how you calculate. Okay. So if it is 20%, it's 200 milligram per ml. So you calculate 5 ml is 1 gram. So if you are giving 100 gram, it will be similarly you have to calculate. Okay. So these are some points about it. Anyways, next question: a 76-year-old man who has been admitted following cabbage. Uh, he has severe left ventricular dysfunction postoperatively and failed to wean from cardiopulmonary bypass. Now necessitate intraaortic balloon pump. So actually, the question will be around it. The basic mechanism is that when we are putting this is a counter pulsating intra-aortic balloon, okay, and when it constrict during diastole, it increases the left and ventricular and diastolic pressure, and increases the coronary perfusion. Okay, this is one point, and just before systole it dilates it like it you can say it is relaxed. So when it is relaxed, the it decreases SVR, it decreases afterload. So it increases the contractility, that improves the cardiac output. So this is the mechanism of functioning of intra-aortic balloon pump. Okay, now see what they um, so usually it is with low EF, with poor perfusion, coronary perfusion, especially in heart failure because of ischemic cardiomyopathy. It's more helpful. Okay, so how do increased aortic systolic pressure increase left ventricular and diastolic pressure? So this is one point. Reduce aortic systolic pressure, increase preload, increase coronary blood flow, reduce aortic diastolic pressure, left ventricular and increase left ventricular volume, increase coronary blood flow, reduce preload, reduced left ventricular wall tension. Concerning the expected hemodynamic effect of a correctly cited and timed, which of the following is the most appropriate answer? Reduce preload, reduce left ventricular wall tension. Let's see. The aim of intra-aortic balloon counterpulsation is to better match myocardial oxygen demand and supply, and thus improve cardiac function. Okay. The physical premise is one of the counter pulsation, which is context of an aortic intra-aortic balloon inflation in diastole and deflation in early systole, as what I was. Yes. Okay. So inflation after closure of aortic valve, midpoint of T wave after diacortic notch. This occurs in the inflation, and deflation before opening of aortic valve, and the peak of R wave point just before the upstroke of arterial trace when the systole occurs. So this is inflation of balloon in diastole causes displacement of blood both proximally in the direction of coronary arteries and distally. The implication of this is that both coronary flow and distal systemic flow may increase. By inflating during diastole, aortic diastolic pressure will increase. Okay. So, uh, as I told you, that aortic diastolic pressure will increase. Deflation of the balloon during early systole effectively reduces the volume of blood in the aorta, leading to low aortic systolic pressure, thereby excluding and the left ventricular afterload. So, aortic systolic pressure will decrease and left ventricular afterload will decrease. As aortic systolic pressure is lowered, the left ventricle will not have to generate as much pressure to cause opening of aortic valve. The time for isovolumetric contraction is therefore shorter. Also, isovolumetric contraction is the one in which the aortic valve is not open and the pressure is increased in the left ventricle. So volume is the same, pressure is increasing, and when this pressure is more than the aortic pressure, the valve will open. This is the main theory. So because it is reducing the pressure, so this time is shorter. Okay. Since IVC, isovolumetric contraction accounts for the majority of myocardial oxygen consumption. So that's the oxygen demand is reduced. As the LV is able to eject blood more effectively, stroke volume increases and end systolic volume is reduced. Okay. And preload is subsequently reduced and preload subsequently reduced. This leads to lower left ventricle wall tension and option they now we will see the effects. So hemodynamic effects of intra-aortic balloon pulsation, counter pulsation, aorta systolic pressure decrease, diastolic pressure increase. Okay. And left ventricle systolic pressure decrease and diastolic pressure decrease, volume decrease, wall tension decrease. Cardiac output increase, afterload decrease, preload decrease, coronary blood flow increase. Systemic mean arterial pressure increase and renal blood flow increase. So that's the positive effects of intra-aortic balloon pump. Okay. These are the indication and contraindication. Of course, it can cause trauma because it's passed through the direct trauma to the femoral artery as well as thrombosis infection, balloon rupture leading to gas embolism. The balloon is initially programmed to inflate and deflate with each cardiac cycle, ratio 1:1. As the patient improves, weaning can occur in a stepwise manner from 1:1 to 1:2 and then 1:3 to 4. Every one contract every three contractilities, I think that's what they do. There are a number of contraindication and cautions given the propensity of an for an intra-aortic balloon pump to increase diastolic blood flow. It may worsen aortic regurgitation. Okay, so theoretically, what will happen if they are pushing? If the door is open, it will worsen the aortic regurgitation. It should also not be used where there is suspicion of damage to aortic wall, dissection or aneurysm. So these you cannot use. The device is inserted via the femoral artery and therefore should be avoided in patients with severe peripheral vascular disease or bypass grafts. So this is another bypass grafts of the peripheral vessels because it can rupture. Okay. So these are the things which you should be knowing. Indication acute myocardial infarction pending revascularization, cardiogenic shock not reversed by pharmacological therapy, as a bridging therapy in left if ventricular failure pending definitive treatment, ventricular assist device or cardiac transplantation. This is another thing. Facilitation of weaning from cardiopulmonary bypass, refractory ventricular arrhythmias. So again, like the basic thing you should be knowing, that when it contracts, when it relaxes. So, and all the positive effects will come. Okay. So, the aortic systolic pressure is decreased, not increased. Okay. Increased left ventricular and diastolic pressure, it is decreased actually. So reduced in aortic systolic pressure, but decreased preload. So this is also wrong. Increased coronary blood flow, reduce aortic diastolic pressure. So so this is the answer. Reduce preload, reduce left ventricular wall tension, increased left ventricular volume, increase coronary blood flow. The left ventricular volume is decreased, not increased, and coronary blood flow is increased, but aortic diastolic pressure is increased. That's how it is functioning. Okay. So actually, this is written very nicely. If you, that's maximum if they can, they want to ask this topic in even in table viva, and they like it's least likely to be asked. But if that's how MCQs books have a wonderful knowledge. You, if you want, like there you will find in articles as well, this aortic, uh, but that's maximum you should be knowing. If you understand these effects, that's more than enough. That's the whole topic is covered in this MCQ actually. Okay. Okay. You are anesthetizing a patient for right pneumonectomy. Okay. You have successfully inserted left-sided double lumen tube, and the patient is taken into the operating room and placed in right lateral position. You will be surprised at why they are taking, the patient is taken into the operating room. Actually, there are induction rooms. So maybe they are, that's why, yeah, they are using the word patient is taken into the operating room. Okay, because a number of times, in the induction room, they are inducing the patient to increase the turnover. Okay, because it will increase the turnover time. Sorry, decrease the turnover time. Because by the time the room is cleaned, the next patient is ready, and as soon as in that time, patient is immediately transferred. So it saves the time. Okay. So, and placed in right lateral position. Initial ventilator settings are intermittent positive pressure ventilation with a tidal volume of 600, FiO2 100%. Shortly after clamping the catheter mount and deflating the right lung, rapidly desaturates. The peak pressure alarm on the ventilator sounds. So actually, this will be the on the algorithm what we do. Okay. So I think it should be C, because deflate the bronchial cuff or apply 5 centimeter CPAP, administer 5 liter per oxygen, deflated lung, all the things which we do. But the first thing will be to check the position of the tube with a fiber optic scope. I am not sure what they will do here, because let's see. Deflate the bronchial cuff. So what will deflation of, I'm not very expert of actually double lumen tube, uh, how it will help. I think the tube is more in. So if you are deflating the bronchial cuff, it will, uh, let's see, hypoxemia in an anesthetic emergency and may occur with the use of double lumen tubes and subsequent one lung ventilation. Because of shunt and failure to ventilate in this scenario, the most likely reason of sudden and serious desaturation and misplacement of the double lumen tube following repositioning of the patient. Proximal migration of DLT may lead to obstruction of trachea by the bronchial cuff. Okay. Proximal migration, like tube has come up. So the bronchial the bronchial cuff is in the trachea, while distal migration can may lead to obstruction to ventilation of one or more lobes. So this is the optimal position. And if it is, this is the the tracheal cuff, and this is the bronchial cuff. So if it is proximally migrate, it will obstruct. If it is distally migrate here, or right upper lobe flow, or left upper lobe flow. That's proximal migration of DLT may lead to obstruction of trachea, while distal migration may lead to obstruction to ventilation of one of more lobes. Other clues to malposition are decrease in compliance, which may manifest as high peak inspiratory pressures. Okay. Immediate deflation of bronchial cuff may allow two-lung ventilation, while the tracheal lumen, if the double lumen tube has migrated proximally, or restoration of a ventilation to the upper lobes in case of distal migration. This maneuver may restore oxygenation and can be swiftly followed by definitive repositioning of DLT with a fiber optic. The advancement of DLT blindly without deflating the bronchial cuff is not an optimal management due to the risk of bronchoscope. Option B and D are accepted methods to improve oxygenation in the event of hypoxemia that is not due to tube malposition. So actually the other answers, this just a second. So this one, CPAP, and this one, administration to the deflated lung. This is what is called as apneic oxygenation. Okay. So these two are also for hypoxemia. Advance without blindly, that will also be wrong. So like my answer was C. They check the position of tube with fiber optic, but I think this one was appropriate because it will solve the immediate problem where whatever it is, whether it is more deep or more like pulled out or pushed in. Okay, and then they can confirm it with the fiber optic. So that was the key. Okay. So I hope you understand. What is apneic oxygenation known? Do you remember? What is apneic oxygenation?
Sir, in apneic oxygenation, what we do, we oxygenate patient and then we disconnect the circuit or disconnect the circuit from the tube, and patient we will wait for the drop in saturation, and when saturation drops, then we again attach the circuit. This
No,
what I
that is
sir.
something else. No, 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 no. That is apneic oxygen. That is something else. What you are telling is not apneic oxygenation. Apneic oxygenation is the one which we do here. That is your apneic technique. Okay. That is
Okay,
apneic
sir.
technique that you are doing ventilation, and intermittently you are
Yes, sir.
doing apnea. That is apnea technique. That's
Yes,
something
sir.
else. Here you are,
Okay, okay,
the
sir.
patient is not ventilated, the lungs are not ventilated. You have just put a small amount of oxygen going, and it is going like the same technique is being used in a number of like in which the it's going with the flow, not with the like cycles of apnea, inspiration or expiration. Okay.
Okay, sir.
Accelerate or delay the onset of severe hypoxemia during apnea. In the anesthetized patient, the oxygen consumption remains fairly constant at 250 ml per minute. This is delivered to the tissues by hemoglobin, whose oxygen is then replenished on the return to the pulmonary circulation by diminishing store of oxygen within the lungs. The alveolar partial pressure decreases steadily, and not only because oxygen is being removed from the lungs, but also because this oxygen removal generates a substantial negative intrathoracic pressure if the airway is obstructed. So actually, this is the concept of apneic oxygenation. This is in BJ education. You can read about it. So apneic oxygenation is something else. In the one lung ventilation, when we are giving oxygen to the non-ventilated lung, that is actually apneic oxygenation. Okay. 27-year-old insulin-dependent diabetes, of course, is listed for a day case shoulder arthroscopy under GA. He is listed first on an afternoon list, and will take an early breakfast on the morning of surgery. This is again not in our setup. It's not a frequent practice, but in there, because they are doing like this. So uh, I think it is 70-30 mixed start. I think Nova mix twice a day after his morning and evening meals. His HbA1c is 7. What is the most appropriate advice for his insulin adjustment on the day of surgery?
Sir, you skip question number four, sir.
Oh, sorry. Okay, we will do this after it. After this, so
Yes, sir,
we
it's
have
Airway 5, sir.
we will read. So, or let's do it first. No problem. 70-year-old woman is receiving laser therapy to the vocal cords polyp. Her grade 1 intubation with laser resistant cuffed tube filled with methylene blue was uneventful, and she is being ventilated to 2% sevoflurane and 50% oxygen. Suddenly, the surgeon notices flames and methylene blue around the endotracheal tube, so stops lasering and flooding the area with saline. Actually, this is on the same, that how will you manage, because that is what is the most appropriate next in managing. So stop the flow of all, reduce FiO2 and perform bronchoalveolar lavage, which should not be the first. Stop the flow of all airway gases and remove the endotracheal tube. Reduce FiO2 and pack wet swab, perform a tracheostomy, inspect the. I think this will be the answer. Stop the flow of all gases and remove the endotracheal tube. Let's see what is the answer. Yes. Laser technology allows precision microsurgery and improved hemostasis, which makes it an appealing surgical tool for operating in the airway. However, since lasers generate a considerable amount of thermal energy, they also present a potential fire hazard. Fire requires the presence of oxidizer, oxygen, ignition source, laser, and fuel, this endotracheal tube, all of which are present within the airway in this scenario. Although laser-resistant endocritical cuff offers some protection against airway, they are still flammable under certain conditions. The endotracheal cuff is particularly susceptible to puncture from misdirected laser energy, which will lead to oxygen enrichment around the surgical site and increased risk of catastrophic airway fire. The most important step after stopping lasering, flooding the area with saline, is to stop the flow of all gases, oxidizers, and remove the endotracheal tube. Wet swabs placed around the surgical site prior to lasering can minimize the risk, but should not be used to treat an airway fire. Gauze will not help. In the event of an airway fire, all inflammable materials should be removed from the airway. The patient can subsequently be ventilated with air once the fire is out. To assess for airway damage, rigid bronchoscopy is recommended afterwards. Gentle bronchoalveolar lavage and fiber optic assessment of the more distal airways is of benefit, and if damage is severe, the tracheostomy may be indicated. Smoke inhalation and thermal damage to the lungs may necessitate prolonged intubation and mechanical ventilation. So actually, they will remove it, and then they will put another new tube, and then they will do the assessment. So rest of the things are being done, but the first thing will be to like stop and remove. Another point that here some people use this technique of apnea, which you were saying, Noon. Okay. So here that is doing is that apneic technique, because there is one you will find not frequently done in all the centers, but what they do is there are some number of patients, there is actually tracheal stenosis following prolonged intubation. Okay. So such patients, they are coming with the tracheostomy, and they have tracheal stenosis, so they are not able to wean off from the tracheostomy. So they are undergoing a lot of time. They are repeated sessions of this tracheal dilatation, and they are using laser as well. So what they do is, actually the patient is ventilated through the stoma, the tracheostomy, and usually they cover the area. They put gauzes and everything, but still I have faced two times in my career airway fire with the same surgeon in the same hospital in the same setting. And after that, I was so afraid from him that I used to do the apneic technique. I used to give him 100%, I would ventilate, and then I disconnect, and he is doing the laser. And when the patient starts desaturating, I ask him to stop, and then I attach again the circuit. So to avoid any chances. And actually, it can be, it's not a bad way. It's a good way to manage.
Sir, there is just one question. In this airway fire scenario, there is a concept of flooding the area of fire with normal saline.
Yes.
So should that step should be carried before removal of tube, endotracheal tube, or after removal of endotracheal tube?
Actually,
Kindly clear this point.
I think even in this MCQ, they have told like this, that flood the area. Okay.
Okay,
Flood
sir.
the area. Like, let's see what they have written here. Mm, This is early recognition and unexpected who surgeon stops the procedure. Uh, Anesthetist should stop the flow of all gases by disconnecting. Another team should is extinguish by the fire by flooding the site. Okay, that's what they have told. Water swab must always be available on the instrument trolley. Should remove any segment of burned airway device or smoldering debris. Next, it should re-establish a secure airway using room on air only. Initially via self. What is this self-inflating bag, Noon? Do you know about it? Have you seen it? Is it available in Pakistan?
What?
Self-inflating bag.
No, sir.
Oh
Self-inflating.
my dear
Yes,
brother. This is Ambu bag.
yes, sir. Yes, sir. Ambu
You
bag, sir.
see,
Ambu bag, sir. I
you
got
know,
it,
I
sir.
was catching you and you are caught.
Yes, yes, sir. It's a ambu bag. It's a ambu bag. सर actually मैं वो फायर वाले क्वेश्चन उसमें जरा तो गुस्सा हुआ था. Yes, sir. It's a ambu bag, sir. It's a ambu
Okay.
bag.
So it's self-inflating
Okay, sir.
bag is the Ambu bag. Okay. So uh, actually, it's very confusing. If you ask me, it's very confusing. So that's what they are saying, that one team is removing the tube and one tube is flooding the area. So that's what they are doing. But actually, I think flooding the area, because if we don't flood the area, we are removing with the fire, and it will damage further. So flooding and removing. That should be, I think, the answer. Okay. So this in this folder you will find for laser and the laser and airway fire. Okay, you will find here. Okay, so the next question was on type 1 diabetes. I don't know what they want to do. I think half usual morning dose and take usual insulin with evening meal. Omit usual morning dose, take normal insulin with evening meal. I think because it's a day surgery, so either it will be omit because the blood sugar is not very high. So maybe it will be either omit or half. Normal dose will not be. So usual dose is gone. Either it will be omit or half. Let's see. Half usual morning dose, take usual insulin with evening meal. So that's the patient with well-controlled type 1 diabetes should have having suitable elective procedures will benefit from day surgery as it aims to minimize disruption to their usual routine. and allows patients to resume self-management of their diabetes. Starvation time should be less than 12 hours so that they don't miss only one meal. They should be placed first on a list. Anesthetic techniques that promote early return to normal oral intake should be used. The ideal insulin regimen for diabetics. Uh, okay, so once daily injection in morning. This is the long dose. Take normal dose. Take normal dose. Uh, if it is day morning, if it is one day, I think once daily injection in morning. This is, I think, the long acting glargine, Levemir, Insulatard, and Humulin one, and twice daily injection. This Novamix, Humulin. I have no idea about it because actually this is not our domain. That's why usually the basic theory, if this question is being asked in the exam, actually we are not using these regimes. Okay, we have to convert it into regular insulin. Okay, so our actually this if this question is asked, least likely to be asked in our exam because in our setup usually we are not using the such regime, especially if you are using in perioperative period. We do the predictable regimes. These are long acting, or this 70/30, they are relatively longer acting, so I don't think so we use it. That's what I know anyways. If this question comes, you are very unlucky. Patients that have a HbA1c in the last should be considered for referral to their GP and clinic for stabilization to elective surgery. A high level of plasma glucose leads to greater amount of glycosylated hemoglobin, where glucose bind to the globin chain. This persists for the duration of molecule's lifespan, and so this HbA1c measurements acts as an indicator of glucose control over the preceding 8 to 12 weeks. Anyway, that's point about. Uh, so again, you will find an article here on diabetes and insulin regimes. Here you will go here and go in endo, and in endo you will find diabetes and you will find insulin regimes, perioperative insulin management. Maybe you will find about the long acting regimes as well. This is a good chart to understand. Regular, and because we are using this Lispro or regular, okay? So these are our domain usually. These NPH or glargine, these are long acting. So usually we don't use it. So okay, so I think inshallah we will continue tomorrow. So today our different insulin regimes, you can read Airway Fire and management of hypoxia during one-lung ventilation, intraaortic balloon pump, and some cerebral physiology and brain tumor. Okay, so you please, if you just want to get benefit, you should read these questions so that you whatever we have discussed become meaningful. Okay, so one more thing, Noon, if you can pull out some of the questions from the previous pools and share it to me. Okay, from these topics we can discuss those questions as well. Okay. Okay, Pardeep and Noon and Mohsen. Okay, all of you, thank you very much for joining, and we will continue tomorrow, inshallah. Assalamu alaikum. Jennifer, special thanks to Jennifer, right from Myanmar.